We have no disclosures. So I think this goes unspoken with this group, and you probably know much of this, but I think still helpful to go over some of the background. So for leptomeningeal disease, approximately 5 to 8% of patients with solid tumor malignancies develop LMD. It's more frequent in certain tumor types. It's more frequent in patients with breast cancer, melanoma, lung cancer, but can be across many different solid tumor types. So it continues to be a really difficult clinical problem that many of our patients are facing. In terms of clinical presentation, these patients present with acute onset multifocal neurologic involvement. So things like headaches, neurologic deficits, and importantly, this can be really debilitating for our patients in terms of their quality of life at the end of life. Diagnostically, we detect leptomeningeal disease based on brain or spine MRI, and then positive CSF cytology is the gold standard, although it can be really difficult to actually detect positive CSF cytology. So oftentimes we'll have to tap these patients multiple times to determine that. And even the CSF can continually be negative, but based on their imaging, we have high clinical suspicion and we'll treat them as such. Unfortunately, there are very few treatment options for these patients, and the prognosis is extremely poor. So most patients, after the time of the diagnosis of LMD, the median time to death is about 2 to 6 months, and often, as I mentioned, with poor quality of life during that time, given the neurologic deficits. So it's a really, really difficult and important clinical problem that we face in clinic. And I think as we improve treatments across cancer types, patients are living longer. And I think, unfortunately, that means more of these patients are going to eventually develop brain metastases and LMD. So I think is only going to become more of an important clinical problem as we improve systemic therapies that may not have as good of blood-brain barrier penetration. So the aims of our study were twofold. First of all, we wanted to characterize the baseline cerebral spinal fluid and blood immune profiles in patients with known or suspected LMD. And then we wanted to explore how these profiles changed over time in response to therapy. So really, this was a pragmatic, practical study. If the patient came in that had known or suspected LMD, and we wanted to enroll them on our study and collect CSF while we were collecting CSF for a clinical purpose anyway, but then collect a little bit of extra CSF to send for research. And so worked really closely to collect these samples with Dr. Molisco and then send them to the Chroma lab to do this analysis. Patients, like I said, with any solid tumor malignancy were eligible. The data we're going to present today is specifically in patients with breast cancer, since that's the majority of patients we were seeing in clinic, but we're really interested actually in collecting across solid tumor types. So if you see patients in clinic or in others, in surgery, et cetera, that have LMD and are getting a CSF collected, please contact us because we would love to enroll them in the study going forward. So this analysis includes 12 patients with metastatic breast cancer. And we also collect, in addition to the CSF, a matched blood sample. And then with support from the Chroma lab and Chris, conducted flow cytometry using a 22 marker panel that's shown here. We'll talk about more in a minute. So in terms of the demographic data of these 12 patients, these are patients that had known or suspected LMD. So ultimately, 7 of the patients we determined did have leptomeningeal disease based on clinical or radiographic characteristics, and 5 of whom ultimately we determined did not have LMD. So it made for a nice ability to compare these two groups. So among the 7 patients with LMD, most of the patients, as you can see here, were ER positive and HER2 negative. We had 2 patients that were ER positive, HER2 positive in the LMD group. And in the LMD negative group, there were slightly more ER positive, HER2 positive patients. But otherwise, they were fairly well matched across the 2 treatment groups. I'll point out that these patients were very heavily pretreated, as you might expect. So LMD is often, we sometimes do see it in patients that don't have any other sites of metastatic disease, but can, frequently be seen in patients as a later complication of their metastatic breast cancer. So many of these patients had received many prior therapies. And most of these patients with the LMD were diagnosed with positive CSF cytology, although you'll note that 2 of the patients never actually had positive CSF cytology, but had convincing enough MRI imaging that clinically we determined that they had LMD. Briefly, before I turn over the mic to Chris, These patients, in terms of their median overall survival from diagnosis of metastatic disease to death, as I mentioned before, patients with LMD have a very poor prognosis. And so you'll see on the right, the median overall survival in our cohort of the 7 patients was only 6.5 months from time of LMD diagnosis to death, which is fairly standard with historical controls, meaning that these patients, very much represented what we were seeing across prior studies as well. So I'll turn it over to Chris to discuss the CSF immunoprofiling results.
Thanks, Laura, and thank you to the organizers, Marisa and Michelle, for giving us this opportunity to talk. So I'm going to talk about how we did our flow cytometry gating. So on the left hand, you will see that we sorted out the CSF by CD45 positive cells. And on the bottom, we're just doing by exclusion by granularity. So the non-granular sites would still be our immune cell populations. And then from there, you see the arrow that goes to the CD3 positive T cells that then go into our sorted populations of CD4 versus CD8. And then the final gating that you see on the 5th one is going to be based off of the T helper versus the T regulatory T cell populations. So these are going to be pretty important because these are all manually gated, and we're looking at the total frequencies of each of these immune cell populations. And what we found was in the CSF is that there's this decreased frequency of both CD45 positive leukocytes, as well as in more detail, we have CD8 positive T cells frequencies that are decreased in the patients with leptomeningeal disease compared to those without leptomeningeal disease. So as you can see with the CD45 positive, it's about a 2-fold decrease. And this is even more so robust that you could see with the CD8 positive T cell populations, suggesting that it may potentially be a more of an immunosuppressed type of environment. When we start looking at the ratios of CD4 to CD8, we find that this is somewhat confirmed in that we see that the patients with leptomeningeal disease do have a higher CD4 to CD8 ratios. So they have perhaps a more immunosuppressed type of environment. And we go into more detail looking at the Treg versus the T helper ratios. And this confirms that we do see that there are these increased ratios of T regulatory T cells found in these patients with leptomeningeal disease. And then because in our 22 marker panel, we did have exhaustion markers such as PD1, TIM3, LAG3, and CD38. The one that was the most striking and most robust was seen to be the ones that had the increased frequency of CD8 positive T cells with CD38 positive expression. So it could be suggested that there is a potential population that could be used as reinvigoration for potential immunotherapy, for example. We also wanted to take another approach. So what you saw previously is just conventional manual flow cytometry gating, but we wanted to take this into an unsupervised method where we take all of our 22 markers and we wanted to do an algorithm in order to see what kinds of clusters can we find. And on the left-handed portion, you'll see that you have all patients, all 12 patients that are combined together. And what we have is about 16 immune clusters that were found within all of these patients. And what you have on the next two gradients are gradient densities split by the different patient groups. So you're going to see that there's in an overall broad sense that there's a very stark difference between patients with or without leptomeningeal disease. And if we start looking and diving deeper into the T cell populations, we also validate that we do have these CD8 positive T cell populations, but in more detail, we know that these populations are CD38 high and their TIM3 low in the patients with leptomeningeal disease. When we start looking at the blood, so I guess as a bit of a slight, go back. Okay, perfect. So as part of conclusions that we get from the CSF, this is pretty exciting because we do see that there are very stark differences already seen in the sensitivity of looking at the CSF for immune profiling between two different patient groups. So now that we go into the blood, we were hoping that we would find more examples as well to see if there's any particular differences between our two patient group populations. But as you see on the left hand, we have that there are no changes in the overall frequencies of the CD45 positive, CD8 T cells, Treg T helper ratios, as we've seen previously from the CSF. And moreover, the only thing that we did see on the manual flow gating was that you do still see that there's this increase in CD4 to CD8 ratio in the patients with leptomeningeal disease. So there are some similarities that you can find, but it seems to be that the blood itself may not be as a sensitive marker in order to have these particular differences between our patient groups. So again, we did unsupervised clustering on these immune cell populations, and we get 22 immune clusters. And the only one that was more T cell centric that we found was that there's this decreased population in partially exhausted CD4 T cell markers. So for the example that maybe you can see is that it's PD1 high and CD38 low types of CD4 positive T cell populations that are decreased in these patients with leptomeningeal disease. So I want to draw some conclusions in that the patients with leptomeningeal disease, again, do have a unique immune signature that can be found within the cerebrospinal fluid compared to patients without LMD. And this includes that there's this lower frequency of CD45 positive immune cells and CD8 positive T cells. There's increased ratios of CD4, CD8s. And if we look and dive a little bit deeper, we can see that there's more of these T regulatory versus T helper T cell ratios. And there's increased frequency of these partially exhausted CD8 positive T cells that's seen from both our supervised or manual flow gating, as well as our unsupervised flow cytometry analysis. And that they're very different from our immune profiles from the blood, but there are some similarities. And I've only shared with you just the T cell compartment, but we also did find that there are some differences found in the myeloid compartment as well too. So the future studies is to hopefully have a larger cohort of patients that are needed to help confirm and validate these findings. And a little bit of a little elaboration of that would be that if we could get serial samples from patients that may have started out as brain metastases and then they progress to leptomeningeal disease, and we can have this ability to track and see how the immune microenvironment or the milieu changes over time. And I'm going to share the last part with Laura.
Thank you. So as Chris mentioned, we are really eager to move this work forward. And recently, that work was funded by the Marcus Foundation, which we're really grateful for their support. And we recently received a California Breast Cancer Research Program grant to fund some future work. So in terms of future work, in addition to continuing to look at the CSF immune profile, we're also really interested in looking at the tumor side of things. So looking at the cell-free DNA in the CSF of these patients. And as Chris mentioned, in addition to enrolling patients that have LMD, we're also interested in enrolling patients that have brain mets, but without LMD as of yet, or hopefully they never develop LMD, but in order to understand the similarities and differences in the CSF between these groups and to study them over time. So we're really excited to move this work forward with that way. And as I mentioned before, this work will be in patients with breast cancer, but we're also interested in enrolling patients with other tumor types as well. So if you see patients that do have LMD and are willing to donate some sample to our research, we would be really grateful for their participation. So that's my email. If you see someone, we're happy to enroll them in our study. And just want to thank our mentors. My mentor clinically, Michelle Molisco, has been fantastic throughout fellowship. So grateful to her. Dr. Crummell, Chris's mentor. I think we've been a really fantastic team. And then I've also worked with Lev and Hope and Alexi as well to contribute to this research. So really grateful for this team. And I think in particular, want to thank our patients. These patients were not enrolled in a therapeutic study, so we're really just donating their CSF for our research purposes. So really grateful for their participation. We've also worked with several really fantastic advocates to guide our research and then funding, as I mentioned before. So thank you again for the opportunity to speak today and welcome questions. How does the immune profiling compare with immune infiltrating cells in liver mets? So to briefly answer that question, we as of yet have not compared the immune profile in the CSF with other metastatic sites, which I think is a really interesting question. Chris and I were actually talking today, do any of our patients have resected brain mets that we could compare? And as of yet, none of these patients have had a brain met resected. We actually don't often resect brain mets in breast cancer. We'll often do SRS or other techniques, but sometimes we do. But I think a future direction would also be to compare metastatic sites to understand that better as well.
To make conclusions regarding the LMD patients that the CSF shows an immunosuppressed profile, you need a comparison to an immunocompetent profile. And here you have access to non-LMD CSF in cancer patients, but they've been radiated, they brain mets, et cetera, et cetera. I would argue you need access to normal CSF from healthy volunteers or some other diseases, et cetera. That's really the control that you need.
No, yeah, you're completely right. We previously were trying to figure out how we could get access to patients with normal CSF and had talked to the neurology group. And as of yet, haven't identified a source to get healthy CSF controls, but I think would be really, really important and totally agree.
I have a question about this. This idea of, this is for Chris actually.
Yes.
This idea of exhaustion of the T cells in LMD patients. My question is where this exhaustion is happening. Do you have an idea? Because it's kind of correlated with what saying before, right? It's like maybe you need to get this sample to do some cytokine array to see what kind of cytokines they are present in plasma versus
Yeah. So the question, if I may repeat it, is where did these exhausted T cells come from? And so I would say that we don't actually know that as of right now. We just know that as we profile the CSF, we do see that there's more of these exhaustion markers that are popping up more so than we do see that in the blood itself. The blood doesn't really give us too much of a detail, just because it's just an area that might be more secondary to where we see with leptomeningeal disease, where it's seeding certain parts of where the tumor are, and it's the actual microenvironment compared to the blood. But yeah, that's a really good question, and that's something that we would want to look into in further detail as well too. So, I mean, right now we have a 22 panel immune marker, but that can increase all the way up to however many we would need. So that's a great question.
Are you planning to do some transcriptomics in this?
Yes, we do. So I was planning to do like a site seek so that we can get a little bit more information. I know that there's some groups here at UCSF that has already done transcriptomic or site seek on some multiple sclerosis in the CSF. So it might be possible, but again, there might be some challenges as well, just because with MS, it's autoimmunity, as well as, if we have leptomeningeal disease, if it's an immunosuppressed environment, we may not get enough of these types of cells. But then again, there's a lot of 10x genomic type of techniques out there that can give us a lot of information for a very few amount of cells.
And one last question, sorry. Are you planning also to evaluate the circulating tumor cells that are present in these samples?
I'm sorry, could you repeat that?
The tumor cells. If you have circulating tumor cells into these samples together with this immune cell that you are profiling.
Yes. Part of our work going forward is we definitely want to look at the ctDNA. And so we have yet, obviously didn't present it today, but we're trying to figure out a collaboration and to move forward with that piece of it as well.
Are there mouse or rat models of leptomeningeal disease that you can do more controlled experiments?
Yes, great question. So I have been looking around if there are some mouse models out there. In fact, there was one that I didn't actually know that it could be potentially utilized as a brain met, but you also have the smoothen A1 medulloblastoma mouse model that could potentially be used. But I'd say that it's not as physiological as we would hope for. So I'm still trying to look for a potential mouse model that could potentially work out to kind of mimic this type of leptomeningeal disease space. But also there's other parts where leptomeningeal disease, there's a lot of different tumor types that it could be affected. So finding a mouse model, we might have to go with multiple mouse models of tumors that would then metastasize to those areas.
Can you reproduce the disease by intrathecal inoculation?
There have been papers that have done that previously. We would just need to be sure that, well, the thing is that if you were to do it intrathecally to mimic this particular microenvironment, I think that there's another part that we would need to consider, which is that the primary tumor then is not actually viable, and that you can't see like the spread as it leads into metastasis. So, and I do think that that also plays a pretty pivotal role in terms of how it's going to circulate throughout the entire system to reach the area where you have leptomeningeal disease. But if we wanted to just say, look at that microenvironment, then it could be possible, yes.
I could just add that, there actually, is no, LMD model. Like Melanie Hayden, who's a neurosurgeon at Stanford, who I know is working on developing one. And she says she has a tech who can actually do intraventricular injections. But as you know, this is like really technical, complicated, just like the people that do intracardiac injections to create brain mets models. So I think it is difficult. It's not easy to find someone who's so skilled in like animal work. And better than I do who those people would be at UCSF. And would love to kind of talk to the animal, the animal core to figure out what they can do. But I also wanted to go back to your question or the comment that you made about, the sort of having true controls in terms of people that had not been radiated or things like that. We know this is a small sample, and I keep bringing this up with Chris and Laura about sort of stressing, how did we identify the patients that were considered not LMD? So these were all patients that we thought were suspicious of having LMD because they might have had, in one case, I can think of a patient that had a very, complex neurologic cognitive dysfunction findings with metastatic breast cancer. She subsequently was never diagnosed with LMD, but we did like 3 LPs on her. So she never received radiation. It turns out she got a checkpoint inhibitor on a clinical trial and then developed all these weird symptoms. So we could actually go back and look and see out of those patients that, that were in our not LMD arm, hopefully we're going to grow this. We actually already have more samples than the 12 that are in this paper. I think we have like four or 5 more. So we'll certainly be able to grow that and sort of curate which patients did have whole brain radiation in the control arm. But at this point, I don't think any of them had whole brain radiation in the control arm. So they aren't super different in terms of the kinds of treatments that they've received that would actually change the immune profile, I think, in the CSF. I mean, I think it's important to recognize that, and we would love to have, and also, love to have just people with breast cancer, like maybe metastatic disease, but no brain mets, no LMD. And that's where we're hoping to go, is with these advocates, that say that there are patients with metastatic breast cancer who are so nervous about getting CNS disease that they would be willing to go through a research LP so that we can get those samples. So we are, actively working with the community actively. Yeah.
Yeah. Just in terms of sources of material, including normal CSF, another potential, I know you asked neurology and they said, no, we can't get normal CSF. Another potential source is autopsy. In particular, warm autopsy. I remember when I first started here, I made a big push for a warm autopsy program, and it couldn't get anybody excited. And several other people after me, I've tried to stimulate them, and nobody's gotten anywhere. A warm autopsy program is one of the most fruitful things that can spawn research and get the tissue samples, and including CSF for people who die from other causes, for example.
Right. We absolutely agree, because again, we talked about it just before in this morning in terms of like, if we could really get, a fresh brain tissue sample, or even if it's normal, I mean, that would just help out so much. And that when we do get a sample that does have a resected brain met tumor, that we could also look at that and compare between the two groups. But I would also have to say, I guess another addition to it too, based off of my expertise on the CSF with the studies that I did in Alzheimer's disease, when you're trying to collect the CSF in a mouse as well too, the most that you could potentially get, even with like in my hands as well as in others, you could probably get about 20 microliters. And if you want to do any sort of flow cytometry, you would really have to.
That's why I brought up the rat as the alternative.
Yeah, the rat also, you could potentially get much more. Yeah, I think that the rat would probably be the better route to go too. But I'm sure that probably anatomically I could probably get that too. So yeah.
Okay, so you got the cancer center leadership involved or interested or pseudo interested, and you can yak their tails and tell them we really need a warm autopsy program at UCSF.